All right, let's get started. Welcome to today's Hopkins Business Health Initiative webinar, The Transformative Power of Generative AI in Healthcare Delivery. I'm Dan Polsky, Director of the Hopkins Business Health Initiative. This initiative brings together scholars from across the university who share a mission to advance health through an affordable and equitable high-value health system. We like to call ourselves HBHI. HBHI focuses on the role of business and incentives in advancing this vision. We're very excited to have just moved our spiritual home to the new Johns Hopkins University location in Washington, D.C., 555 Pennsylvania Avenue. For those familiar with the nation's capital, it's once the museum. So as part of this initiative, we have conversations on the business of health, and we welcome the community to these conversations, and we also host webinars. So this month's conversation is also a part of HBHI's work group on AI in healthcare. Our webinar's moderators also lead this work group, and they've just done a tremendous job running this work group and organizing this webinar. So best for me to turn it over to them. So let me just do brief introductions. Ting-Long Dai is a professor of operations management and business analytics at the Johns Hopkins Carey Business School. And Dr. Risa Wolf is an associate professor of pediatrics in the Division of Pediatric Endocrinology at the Johns Hopkins University School of Medicine. Thank you for all you've done to put this together. And I'm looking forward to the webinar. I'm going to turn it over to you.
Thank you, Dan, for your kind introduction and for your support of our work group on AI in healthcare. We've been running this work group now for almost a year, and we're proud to open it up to the larger outside of just Johns Hopkins. So now allow me to introduce one of our speakers, Dr. Chris Callison Birch, an associate professor of computer and information science at the University of Pennsylvania. Notably, his artificial intelligence course at Penn attracts over 500 students each fall semester. Dr. Callison Birch is a leading voice in the fields of natural language processing and crowdsourcing. He's currently exploring how large language models like ChatGPT can solve complex challenges in artificial intelligence. With a track record of over 100 publications cited more than 20,000 times, he's an influential thought leader as well. His accolades include being a Sloan Research Fellow and securing research awards from tech giants like Google, Microsoft, Amazon, and more. And recently, he even testified before Congress on the topic of generative AI and copyright law. So it's an honor to have him with us today, and I'll turn it over to Ting-Long, and he'll introduce Dr. Curtis Langlois.
Thank you, Risa. It's my pleasure to introduce Dr. Curtis Langlois, who holds multiple leadership positions at Stanford University. He serves as professor of radiology, medicine, and biomedical data science. Dr. Langlois is also director of Stanford Center for Artificial Intelligence in Medicine and Imaging. He also serves as associate director of Stanford's Institute for Human-Centered Artificial Intelligence. He oversees an impressive imaging study library that boasts over 8 million entries at Stanford Radiology. His lab is at the forefront of using machine learning to detect diseases and reduce diagnostic errors. He has authored more than 150 publications, a book, and several standards and terminologies in radiology. He has previously served as the president of multiple radiology societies and currently chairs ISNA board of directors. His impactful work has also led to 3 startups. We are thrilled to have Dr. Langlois join our conversation today. Now, in the rest of the panel, what we are going to do is that we're going to ask several rounds of questions, and then we are going to open up a conversation and with the audience. So the first of all, so we're going to do the first names, by the way. So we're going to so Chris and Kurt, and welcome, and thank you very much to join us. I'd like to invite both of you to speak about your own work in incorporating generative AI into healthcare delivery. Could each of you maybe give us a brief 5-minute overview of the work and perhaps some stories about how you were drawn into this fascinating field? Thank you. Maybe we'll start with Kurt and Chris.
Well, thank you, Ting-Long and Risa. It's just a pleasure to be here. This is such an important and interesting topic, so I'm looking forward to the hour. I guess my story starts back when I was doing my graduate work here at Stanford in AI. And at the time, this was one of the first bubbles of AI, and we were told that we were learning to be knowledge engineers. And what that really meant was we, as engineers, were partnering with the domain experts. So we might find someone who knew the various manifestations of sepsis or could distinguish a benign from a malignant breast mass. And we would understand from them those features. Then we would go back and implement systems that would help to detect sepsis or determine a malignant breast mass. And so those systems typically would take 4 years and a PhD to build just a proof of concept. And now I think it's much different. Nowadays, with the right training data, we can build a system to do those tasks in a matter of a few days or a week or two. And the accuracy is even better than what we had back then. Fast forward to about 2015, I had just joined here at Stanford, and Fei-Fei Li, who currently leads our university-wide Institute for Human-Centered AI here, was giving a talk and showed an example of automated captioning. So it was a photograph of a breakfast table, I think, and various objects on the table had been automatically bounded by a box, and each box had a text caption, all of which was generated automatically. And I think when I saw that as a radiologist, I said, that's what I do. I look at images, I describe them in text. And so I think a number of us just recognize the incredible power of these methods when applied to healthcare. And that really caused me, I had spent most of my career analyzing text and doing natural language processing and thinking about communication between physicians. But at the time, then I shifted my lab's work more towards image analysis. And ultimately, we started the center that you mentioned, Ting Long, the Amy Center, which is the Center for AI in Medicine and Imaging. We have over 150 faculty now who are involved in the center and across 20 departments here at Stanford, all of which are interested in these very issues. So let me just give you a couple of examples, and I would divide it into two categories. One is the use of off-the-shelf language models. So my colleague Patty Garcia, who's one of our associate CMIOs, is leading a project you may have heard of, which is using these language models to help with in-basket communication. So the kind of email communication between patients and physicians, and finding that some of those messages can, of course, they're all approved by humans, but can be easily drafted by these language models. And that can be an incredible help to those who are responding to these queries from patients. Another example is something from my laboratory where we had previously built a technology that can extract knowledge graphs, so concepts and relationships between concepts from a text result, a radiology report, which is, of course, a communication between physicians. And increasingly, patients now have access to their digital data on an app or a website. And so they're seeing their radiology reports and often don't understand, I can tell you from my own family, don't understand the concepts that they're seeing in these reports. So we use this technology to extract those concepts and then to create prompts to these language models and get responses at the reading level that the patient prefers and in the language that they prefer. So we can then create a hyperlinked text result where the patient can click on concepts they don't understand and get an explanation and perhaps start a dialogue that would help them better understand their care and their test results. So that's kind of the off the shelf. And then the other category I would say is more, we're thinking about what does the large language model revolution mean if we were to apply it to the large amounts of data? We have a petabyte of imaging data here at Stanford. We have all of our EMR data in a research repository. So if we were to take that, so my colleague Nigam Shah, his lab is, rather than thinking of language as a sequence of words, thinking of it as a sequence of medical events. So the patient has a clinic visit. Maybe they were given a diagnosis. Maybe they had an imaging test. And so you can use the same methods to not just to predict the next word, but to predict the next event and how long it will take before that event occurs. So that's something that can be very powerful and can be used across different kinds of decision support applications. The other area that sort of build our own has to do with using these language models, these generative models. You may be familiar with those models that create images. There's one called DALL-E, one called Stable Diffusion, which we used and adapted it so that it could create synthetic imaging data based on a prompt. And what we're finding, and this is work that's done with Akshay Chowdhury's lab here at Stanford, is that that synthetic data can be used to supplement the labeled training data that we would use to create a diagnostic imaging model, and improves the accuracy and the robustness of those models. So that's just a sampling of the kind of work that we're doing here, and that's being done across the country and across the world, and look forward to talking more about it.
Thank you very much.
Wonderful.
Chris.
Hello, everyone. My name is Chris Callison Birch. Like Kurt, I've been in the field of AI for quite a long time. I did my own PhD starting in the year 2001, and the field has made amazing progress over the past couple of years. I was working with language models before they were large, I guess I like to say. So we've seen really amazing upticks in the capabilities of these systems. So I've been in the subfield of AI called natural language processing for those 20 years. I actually started my faculty career at Johns Hopkins University, where you're extremely blessed. You have not just one, but two centers on the Homewood campus that focus on speech and language technologies with a lot of amazing researchers, including some who span the boundary between computer science and medicine, like Suchi Saria and Mark Dredzy, are really fantastic resources for all of you to have. So I've been working on a ton of different language-related things, and of course, I was probably on the front lines in seeing my own field swallowed by OpenAI's ChatGPT. One of my colleagues jokes that NLP invented technology that made itself obsolete. I kind of had this career existential crisis when I got to see the capabilities of OpenAI's system in a private beta about 1.5 years before everyone else did. And it could do these amazing things that I previously had thought were all first order research questions that I would assign my own PhD students to do. Things like translation into other languages, things like automatic question answering, things like rewriting a text to be more understandable to a lay audience, removing all the kind of technical terms that we as AI researchers or you as doctors use. And it was really a jaw-dropping moment for me. So I've gone through many iterations of reactions to this, as I think all of us have, starting with fear and panic that my career may be obsolete, and trying to find my own footing and how to use these technologies in an effective way. So I've calmed down. I don't think ChatGPT is going to replace all computer scientists, and I don't think it's going to replace all physicians as well. So trying to figure out like what are good applications of this technology, I think, is key. So the technology, and I think crucially, it's important to understand what things like large language models can do and what they don't do. I think because of the hype, it seems like AI can do everything, but I think it's really important to understand what its capabilities and limitations are when you're trying to decide how to put it into your own work. And we're here to help guide you through that. But I think that there's like some cautionary tales that have happened recently that are worth flagging, just so you don't become a cautionary tale yourself. So the New York Times had a piece about a lawyer who used ChatGPT to write a brief, which he submitted to the court without fact checking and without editing. And I think because large language models like ChatGPT generate such incredible, plausible text that really sounds convincing, it's easy to believe what they're saying. But I think the key to understanding them is they're not doing any fact checking by default, although this is changing. They're not retrieving documents to compare their answers against. And because they're generating text word by word, just like your cell phone is doing when it's doing autocomplete, they end up hallucinating things that sound really convincing. So that lawyer had the output of a ChatGPT system that cited past case law and particular cases that helped his client and reinforced the case that he wanted to make, but they were made up from whole cloth. So I think there's tons of incredible applications of this. So I've been advising a startup company called MangoMind, which is building a physician's reference document using technology like ChatGPT. So you could essentially have a conversation with it and ask questions that are highly technical. And rather than having to retrieve a whole document, you could have a personalized answer that both matched your hospital system's guidance and also directly pinpoints the part of the reference document that is relevant to your question. In my own research, I've also been looking at explainable models of artificial intelligence. So I think that that's also a crucial thing for critical applications like healthcare, where if you wanted to diagnose something or predict whether or not a radiological image had a cancerous growth, you wouldn't want a simple black box artificial intelligence system to say yes or no. You would actually want additional accompanying information that you could validate as an expert in the field to understand its reasoning. And then you would also want that reasoning chain to be faithful to how it was making the decision. So those are some of the technical contributions that my research group is attempting to make. And then since the release of ChatGPT, I've been trying to do broader scientific communication to all sorts of different groups. So when ChatGPT came out, I had the luxury of being on my sabbatical. So I sort of volunteered to talk to anyone who wanted to know what this technology was. And I started with Penn School of Medicine here and tried to walk them through it. And then I went all the way up to Congress to talk about potential implications for this technology. So I'm happy to provide a understandable explanation of how the technology works or answer any questions that you have about it.
Thank you very much, Chris and Kurt. That's really fascinating personal histories, but I'm a big fan of history. I like to talk about history of AI. And so one thing I like to talk about is that AI and medicine always have this really intimate relationship, right? Even neural networks were inspired by brain science, and not to mention radiologists always being at the forefront of things in terms of AI and medicine. And it's good to hear from you, Chris, how you got into medicine. Now, I want to turn to Risa. So Risa I've been working with Risa for a long time, but she's also one of our AI heroes here at Hopkins, in the sense that she has been pioneering the use of AI in healthcare delivery. So I want to see from her perspective and about your thoughts surrounding AI and healthcare delivery.
Well, thank you, Ting-Long. I mean, I think that we've been using what many of us would call like practical or diagnostic AI. It's not generative, but using it in practice. And we've just here been using IDXDR, which diagnoses diabetic retinopathy, which is FDA approved for adults. We've been using it in pediatrics for the last 5 years under a research protocol and research studies, but really just working through the implementation, validation in a healthcare system, which has created its own source of challenges as well as successes. It's definitely helped us improve screening for diabetic retinopathy, mitigate disparities by improving access to care and access to screening, which has been great. But of course, it always comes with challenges related to accuracy, sensitivity, specificity, implementation, even like the technological part of working these devices. So I think there's a lot that we can learn from that, despite I think the successes that we've had. So both of you have done so much amazing work in this area, but I'd love to sort of pick your brain a little bit more about how do you think physicians are actually going to be using AI tools like ChatGPT, Claude AI in healthcare delivery, like practically, and what do you think are going to be? And I know you started to address this, Chris, but some of like the successes, obstacles, pitfalls that we're going to encounter as more and more people begin to use these technologies. And clearly the implementation is widespread, but not in completeness at any institution at this point.
Yeah, so I think that that's a question that we're all grappling with across all different fields. So like for our School of Engineering, I'm trying to record videos for our staff members on like what are appropriate and inappropriate uses of technology like this in your own workflow. And I think clearly in medicine, the stakes are heightened because you have important things like privacy considerations for patient health records, and you have health critical decisions that you have to make, and all of these things will play a role in like what is appropriate versus inappropriate uses of the technology. So I guess I wanted to highlight like a couple of the tools that people have access to just as general consumers on the internet. So ChatGPT is the most notable tool. And so that's something that everyone can access for free. You can also buy a $20 per month license that unlocks additional tools. So one of the tools that it unlocks is called Advanced Data Analytics, that essentially lets you upload spreadsheet data and ask questions about it. So for my own computer science research, I found myself doing data analysis of spreadsheet-like data by having a conversation with the machine. So I think that that gave me the capability of doing things that I know how to do, but takes me a lot longer to try to do data analysis and visualization and all these sorts of things. So just having that as a conversational device is incredible. Of course, I want to highlight like there's privacy concerns. For me as a professor, we have the student equivalent of HIPAA. We have FERPA, which is educational privacy law. And so I'm always careful to remove any personally identifiable information from spreadsheets before I upload them to GPT to have a conversation about it. Another great tool that people might not be familiar with is another large language model called Claude. It's from Anthropic. And I've been using that because it allows you to upload documents and have conversations about them. So you can upload a scientific research paper and discuss it with the robot. I've been taking shortcuts when I'm writing my annual reports for DARPA or National Science Foundation by uploading my own research and asking it to summarize the main contributions of the research in a way that's understandable to program managers and things like that. And that allows me to also fact check it because I know the papers intimately, and that's really great. So there are lots of tools, and I think that we'll explore the ways in which we could integrate them into our workflow.
Yeah,
Thank
and Reese, I was just going to jump in and say, first of all, I agree with Chris that the explanation is really important in healthcare. These models are likely to be working in partnership, humans and machines, and so explanation, and even I would generalize that to the issue of trust. Like there are many things outside of AI that we don't really know how they work in medicine, but we trust that they do because they've been shown in clinical trials. So I think we have our work cut out for us to show that these technologies actually improve care. The other, I think, important issue for the models out of the box, like Claude, ChatGPT, and others, is that these are a different kind of intelligence, and we have a possibility of being seduced, a kind of automation bias where, gee, it sounds smart, I probably should believe that. But I think if you map out human knowledge, we make a number of assumptions rightly that human beings may have particular areas of expertise. You know, I know radiology, I know AI, I'm very deep there, but I know how to add and subtract and do a lot of other things to plan a sequence of actions to accomplish a complex task. And those are just assumptions that we make about humans. And when we hear these models speaking in that way, we think that they have that same kind of broad knowledge, but there really are gaps in the knowledge that can be significant problems, things like simple math and planning. And Chris mentioned the issue of citations, that it has had a problem in the past. So that's where I think there really is a need for that validation. The other thing I would say, and this gets back to, some of my earlier work was really related to decision theory and probabilistic reasoning. And you have to think about these systems if they're being used as a diagnostic decision support, for example, providing a differential diagnosis. Where are its prior probabilities of disease coming from? Like we go to through all this medical training to understand the likelihoods of diseases and the relationships between symptoms and disease. And, these models are just trained on the entire internet. And so do you want, my colleague Nigam Shah likes to say, do you want your doctor trained on Reddit? It may relate more to some disease that a celebrity had that got mentioned a lot of times or something else than what you would truly want to have happen. So I think there's a longer road there. So I think in terms of where these applications may be more likely to be applied is in patient communication. I gave some examples of that. Some of the back office functions and billing and those kinds of things are some of the early applications versus the decision support, diagnostic decision support, which I think might come a little bit later and might be more related to when we take this ChatGPT model, this method of training, self-supervision, and bring it to very large amounts of health data, which hasn't been done much to date. There was actually a really nice article this last week in Nature about a massive model trained on a large amount of ophthalmologic imaging data that has a number of really interesting capabilities, label efficiency, and increased accuracy on a wide variety of downstream tasks. So that's exciting too.
Yeah, and if I can just jump in and re-emphasize the point that Kurt was making. So this notion of building trust versus trusting the model too much, I think is super important. So, and sometimes I draw the analogy to a self-driving car where if 99.9% of the time it's driving perfectly, that's still insufficient because the remainder is going to cause you problems. And it will also potentially lull you into a false belief that it's better than it is. And I think that all of the things that Kurt mentioned as things that are not current capabilities of these large language models are super important. So it generates text extremely fluently, but it fails to do simple mathematics. So because it's been trained on words that it's seen on the internet, it can probably do 2 + 2 = 4. But if you give it two arbitrarily large numbers to add together, it's just going to pick some other arbitrarily large number and not actually do the computation. And so anything that requires computation or reasoning beyond just words, it's not really set up to do. So planning, probabilistic reasoning, both of which Kurt mentioned, are things that are beyond the current capabilities. I think that they're likely to potentially be integrated into the future, but I think that that also has huge implications for where it should be used at the moment.
I think these are all really important sort of maybe cautionary tales about really the limitations of generative AI. And, I think you're right, like people are using them in some capacities, but not fully. I mean, there's been a few articles. There was an article recently I read about ophthalmologists, like taking patients showing up to the ER and then putting the data in and then actually getting accurate diagnoses. And, there's been some, flashy stories on, NBC Today. There was one last week about a mother who took her son to like 17 different doctors who couldn't find a diagnosis, and then ChatGPT figured it out. So there's all the sensational stories too, but I think, obviously the limitations are really important for all of us to keep in mind as we move forward. I'm going to let Ting Long ask some additional questions.
Thank you. That was really, really fascinating round of insights. And so now, Kurt, I know you are a radiologist. So radiologists, to my best knowledge, are really, really fascinated by AI and made an important contribution. I would say maybe 75%, 80% of AI devices provided by FDA so far have been developed by radiologists. So my question for you is that, do you think generative AI needs to be approved by agencies such as the FDA or other new agencies before they're being used in medical practice? The reason I'm asking here is that all the medical students I know of, they use ChatGPT in one way or another, right? So the universities and medical schools may have one policy, but the reality is that everyone is using it. So I teach this MBA level artificial intelligence class. Quite a few of my students are medical doctors. They are saying that, well, we have all sorts of AI policies, really essentially saying you cannot use generative AI unless you clearly cite them or disclose them. But on the other hand, you clearly see that the deans are using generative AI, right? The presidents are using generative AI. So what's your take about it? What kind of approval we need before generative AI being used on a massive scale?
Yeah, thank you, Ting Long. It's a really interesting set of questions, and you're right. Radiology is leading the way. I think because we have just a large amount of digital data, and these models just happen to be very good at analyzing imaging information. So if you look at the FDA cleared algorithms, as you say, 3/4 of them, several hundred now are radiology focused, and even more are imaging focused. And I think that'll probably continue. And the FDA is in a little bit of a difficult spot. I think they're doing a very nice job of balancing, the need for safety versus also progress and the benefits that these algorithms can bring. But FDA clearance is still somewhat of a low bar, and I think there are many customers out there, and we have at our annual RSNA meeting, which comes up the week after Thanksgiving every year, a massive area with over 100 vendors that are selling these products now, these AI products, and many practices have begun to adopt them. So it really is an industry. In terms of your question, first of all, I would say I think we are in an advantageous position in healthcare in that we already have an agency that regulates these kinds of things for safety and effectiveness. And I think that's important, and that's going to help us actually relative to some other industries. In terms of your question, what needs approval or clearance? I think unfortunately, it depends. So I can tell you in my practice, I use search engines all the time to look something up. I need to remember what are the different Salter classifications of pediatric fractures, because I don't see pediatric patients that often. It's good to be reminded of that. I can search that. And I'm sure physicians and other caregivers will be using these language models, asking them similar kinds of questions. If that kind of interface to the internet is better, is more useful for them, I would say, that's wonderful. And I suspect that's not something that would ever need to be cleared or approved. On the other hand, if you are taking patient data and feeding it to one of these models in a HIPAA compliant manner, and then getting a differential diagnosis back, that looks a lot like a decision support application of the type that probably does require some regulatory approval. And it's going to depend to some extent too, I think, on whether there's a human in the loop. So things that suggest, for example, the note that we might write, but that we are editing that note, I'm not sure that would require approval. But again, if it's truly decision support and there's less of the human in the loop, I think that's an area where we're going to see that. Incidentally, one other point about regulatory, and that is that if you think about it, the regulatory environment we have now is focused on approving or clearing fixed devices or software devices. And that's really not where the AI field is heading. If you think about these large generative models, we're going to start seeing them. I just mentioned one in ophthalmology. I'm sure we'll see them in radiology and for the EHR, where you have these models that are trained in a self-supervised manner on large amounts of data and then get fine-tuned on, it might be a specific task, it might be a specific set of patient data from a particular healthcare organization who has a particular patient mix or what have you. And so it's likely that you'll want to take a large model and then fine-tune it into a specific circumstance. And so the FDA recently announced this notion of a predetermined change control plan, acknowledging that you may have this massive pre-training and then fine-tuning into specific circumstances. And I think that's going to be a trend as well.
Thank you, Kurt. I think the predetermined change plan you talk about actually relates to the notion of continuous learning. How do you make sure you update devices frequently, hopefully not too frequently, but somewhat frequently, and to update your medical devices. And I think it's also applicable to generative AI. Now for Chris, I'm going to ask you this particular question that when I talk to some of my medical colleagues, some of my colleagues from non-healthcare fields, one concern I heard from is that ChatGPT is too nice. It's too nice and too agreeable. It tends to agree with what you say. If you ask ChatGPT to critique your research paper, it tends to say tons of great things. It's very insightful, very innovative, right? It's not like review tool, right? So the question is, have you seen any, have you observed this phenomenon called, sequencing, in which the model generates responses confirm or cut to users' preferred response, which could lead to risk of misdiagnosis in medical context? And also, because you are an expert in language models, do you suppose that is a real thing? Do you think that's something that can be eliminated as this large language model gets better and better over time?
Yeah, that's a really fun observation. So I've seen it too in my interactions with ChatGPT, where it'll say something, I'll correct it. It'll be very apologetic for being wrong, but super sycophantic. So that's actually a good thing to discuss on why it behaves that way. And it relates to something that Kurt just said about you can adapt these, so you can adapt models via fine tuning. So just for everyone's benefit, the initials GPT, it's good to know what those stand for. So G is for generative, it can generate text. P is for pre-trained. So it's been pre-trained on 1 trillion words that have been harvested from the internet. So that's why it knows so much seemingly about the world and why it can generate such plausible sounding text. And then T is transformer. It's the kind of neural network that it uses. So the chat part of GPT is taking that pre-trained model and then fine-tuning it, which means changing its behavior through a series of examples where OpenAI has modeled the kind of behavior that it wants the system to have by hiring human annotators to say, when you get a question like this from a user, your response should look like this, where they've actually written something out. And that tends to be polite and deferential and all those sorts of things. So that behavior is emergent from not the GPT itself, but through the fine tuning so that it's a good chat assistant. So the exciting thing about these models is pre-training a model on huge amounts of data, whether it's text for large language models or images or computer vision systems, has become this winning strategy for then tackling nearly any kind of task that you're interested subsequently. So the starting point of the pre-trained models gives you an amazing base to build on, such that you can rapidly adapt them to the particular application. So if you want to adapt a computer vision system to analyze radiology images, you've pre-trained on non-radiological images from the internet, but that still gets you a lot of amazing capabilities that makes it do it much, much faster. So rather than using tens or hundreds of thousands of radiological images paired with their labels, you can now cut that amount of data down to something much, much more manageable. So that's one of the main ways that these systems are going to be impactful in the future is the strategy of pre-training and then fine-tuning seems to win almost every machine learning task that I've seen over the past few years has been that formula wins. So if you've got, and that also suggests that like if you have a particular task and dozens or hundreds of example data, which previously, machine learning researchers would say, oh, you need 1 million examples before I can give you anything. Now we can give you something. And we can often adapt to your task in a surprisingly good way.
So does it look like we can train ChatGPT to become really critical and not overly differential, interactions, right?
Precisely. So if you wanted a version of ChatGPT that was non-deferential and that had a different mode of interaction, it's actually pretty straightforward to do that with a few hundred or a few thousand examples of the types of interactions that you would want. So if you wanted to model like a particular bedside manner for something that engaged with patients, you could do that, and it would mimic that behavior in the same way that it's mimicking this deferential assistant.
Perfect. So the four of us, we're all educators in some way. And so a lot of people in the audience are also educators. So I will turn to Risa to ask a round of questions about the implication of generative AI on medical education.
And the discussion thus far has been fascinating, and there's actually quite a few questions in the Q&A as well. But I'll just ask you one more question related to generative AI in the healthcare setting. We've changed a lot in the last, you saw it even earlier, 3 years ago. In the last year, things have changed a lot. And just the number of FDA-approved just diagnostic AIs has increased probably by 100 a year or so over the last few years. Where do you think that we will be with generative AI in healthcare in the next 5 to 10 years? And thinking about how it might shape medical education, residency training, or even research?
Yeah, great question. I think I think back to an example, and this dates me a little bit, but when MRI first came out, okay, there were those who thought, wow, those images are just so clear. We won't need a radiologist. We'll have the patient go through the MRI, and the abnormality is just going to show up so clearly that the primary care physician is going to be able to see it and make the treatment. But it turns out that MRI devices are quite complex. And so understanding the physics, a little bit of the physics of how they work, can help you distinguish, for example, some artifacts that you might see because of the phase direction of the encoding of the information. And so that's why we incorporated this kind of MR physics training into a radiology residency. You have to understand, you don't have to build an MRI machine as a radiologist, but you have to know enough about how it works to understand its shortcomings. And I think that same principle is going to apply to AI, that we need to understand the way that these things work in a general way, enough to understand the failings. And I gave one example, and this comes from Andrew Ng, one of my colleagues here at Stanford. I ask our trainees, which do you think is more likely to get the right answer from ChatGPT or another language model? If you say, state the problem, and then you say, please give me your answer and explain why you think that's the right answer, versus state the problem, give me your reasoning why you think it's the right answer, and then give the answer. And the answer is the latter is more likely to get the right answer because you're priming the model with its own thinking. It's not jumping to a conclusion quickly based on very little previous text. And so that's just one small example of how understanding a little bit about how these models work, the fact that they're just probabilistically generating the most likely next word, can help you understand why it might be stronger in one area versus another. I think we absolutely need to have that in our medical training. And we're already doing that kind of thing, both through national organizations like the RSNA, as well as through our residency program at Stanford, for example.
Yeah, and I think the notion of how these will be integrated into education broadly is also a huge issue. I think that we had like a pen-wide all-hands meeting when ChatGPT came out, because it does feel like this is going to transform how education is done. And I think everyone's initial fear is like, oh, students using it as a device that's essentially a plagiarist's tool. But I think that there's lots of additional uses of it that is like customized educations that can be personalized and targeted towards your specific level of knowledge and your specific background. So Riza, you mentioned earlier that there was this NBC Today story about a mom who used ChatGPT to diagnose her son who had failed to be diagnosed by a bunch of doctors. And, I think in some ways that shows uses of this kind of technology for patient-driven education, where they're trying to become more informed themselves. And I think it kind of shows how this technology is in some ways supplanting things that would have previously be done via web searches. I think the fact that GPT is trained on Reddit, like Kurt mentioned, but also other websites like Patients Like Me and things like that, means that you can potentially get information that would be hard to surface through a simple web search. Like you can't really pin down enough about the context of what's happening to your child or yourself as you're a patient trying to search for information using keyword-based queries. But by having a conversation, you might be able to surface it and kind of pull in these patient descriptions that would have happened on these non-medical sites, but where patients are communicating with each other. And so that gets encoded in the model too. And so patient education, doctor education, all these sorts of things are going to be things that get transformed based on this technology.
I think those are all great points. I think it'll be really interesting to see, you know, sort of where things go. I mean, even now, you know, some people are using it as an assistive device to, you know, double check, or might be using it really up front. And, you know, we earlier this week, our Dean DeWeese actually hosted a webinar similarly on AI in healthcare, not necessarily generative AI. But, you know, sort of one of the comments that was made is that, you know, in 5 to 10 years, like the future is that maybe in, you know, lower resource settings, the use of ChatGPT could be helpful, but then also that, you know, the physicians who don't use it might be the ones who are left behind. So I don't know what your thoughts are on that, but, you know, these are some of the things that have been said recently. But I definitely think we're going to see lots of changes and really probably even increasing use. But I think it'll be also interesting, like who's using it, in what settings, how we're using it, and really how, as you said earlier, Kurt, like how it impacts patient care. And hopefully all for the better, but that will be something that's, you know, sort of iterative over the next couple of years. So
and I think, sorry to interrupt. I think a mechanism for exchanging like how you're using it with your colleagues is something that we've found very useful within our network of professors who are like saying, oh, how do we use this effectively in our classrooms, and trading examples where it was successful or unsuccessful. Like that can be super valuable. And then also to understand that it's going to change over time and new capabilities are going to be introduced, and so, you know, I encourage everyone to try it out. Like you should play with it and try to understand what it is and what it could be useful for. But that your first try you might not get something useful. There's a little bit of an art to formulating how you pose prompts to it and how you work with it. Yeah, and then there'll be new capabilities that get added. So I'm beta testing something with OpenAI that allows you to discuss images as well as text. And it's jaw-dropping when I feed it figures from scientific papers. It can really cogently discuss them and analyze them. So it's exciting to see what's coming.
Well, I definitely learned some tips from you today, so it's helpful.
I think that's a trend that we're going to see in medicine too. We are seeing is multimodal, right? We've got EHR data, which is both structured and text. We have genomic information, we have imaging information. Bringing all of those sources together in one of these models is going to be incredibly powerful. So those kinds of things that we're seeing outside of healthcare, soon enough, we're going to see those same kinds of models developed within healthcare with our own data.
Actually, Kurt, there's a question for you in the chat, specifically related to this and sort of the EHR data. That earlier you mentioned the use of in-basket messaging using these models, and the specific question is that about integrating ChatGPT and Epic EMR, because we use Epic here, so it's always a question for us. And really, how much do the doctors trust the compliance with patients' privacy, and what are your thoughts on that?
Yeah. Super important privacy. So we would not ever have we would never submit patient data as a prompt to ChatGPT. So OpenAI has a partnership with Microsoft. Microsoft has a partnership with Epic, our electronic health record vendor. So we have an instance of this technology that is HIPAA compliant and private and in our own private instance. So when we send information to these systems, it's done in the same manner as we would keep patient information private in any of our systems. It's not in the OpenAI servers. It's in our own private environment and kept private like all of the other patient data. And I think that's a really important question. People raise the issue of privacy, not just in that instance, but what about the training data? Well, fortunately, ChatGPT is trained on the internet, so that if the data is out there on the internet, the information you get back from it, from these models, is no different. It's that same public information. The difference will be now, as we apply this large language model or self-supervision model that created ChatGPT to data that we have within our health systems. It'll be an interesting transition because, for example, our center at Stanford, we've released now more than 20 AI-ready data sets that were used to create our AI models here at Stanford. And then when we're done with our experiments, we make it available to the world and encourage others to try to do even better and innovate using those same data sets. But when you get to these very large data sets that are trained on patient data, and we of course would train it on de-identified patient data, but there's always that question as to whether that model then married up maybe with some other data that's publicly available could be used to identify a patient somehow. So I think we're going to be much more cautious as we start to train these large models on actual patient data about how public we can make them, but we want to make them as widely available as we can within that private setting because we see the benefits that they can provide to patients.
Thank you.
That's excellent. So there's a question in the Q&A asking whether anyone at GHU is working on more general validation workflow for clinical applications, integrative generative AI. That looks like Stanford does have a very systematic approach. At Hopkins, I think we are aware of several independent efforts to achieve just that, and encourage everyone interested to reach out to me and to Risa, and we can discuss. Hopefully we can do something like Stanford has been doing. And then related to Kurt's point that you're making your AI model open to the rest of the world, there's this question in the Q&A about how can we use generative AI to address global health challenges or disparities in the future? So do you see the potential for generative AI to actually improve access to quality care like we are blessed to have?
Yeah, I mean, I would broaden that question not just to generative AI, but to all of AI. And so we see AI can have these decision support tools can have a number of effects. Number one, I think that as we were talking earlier, the kind of intelligence that's provided. So just a specific example, the kinds of lung nodules that are detected by an algorithm are different than the kind of lung nodules that are detected or missed by a human. And so when you put the two together, you actually get a larger set of lung nodules. So you have better detection overall by putting those two complementary factors together. So one effect is you can take physicians who are at the top of their game and improve them further. The other is there's good research to show that you take physicians or caregivers of any type who are maybe not as good as the very best, and you can really upskill them. You can make them better. We've done some early work on interpretation of chest X-rays in the developing world, and that's you can imagine. So a large portion of the world is underserved by radiologists. So just having these tools available to other kinds of caregivers, or even here within our country, there are areas that are underserved or may not have a radiologist in the middle of a night at a small hospital, and it'd be very useful in that mode as well. So I think it's going to have those effects across the board, and certainly in areas that are underserved, these can be very powerful.
And I think also there's implications on the patient side as well for access to information. So, I think one disparity also comes from language barriers, and whether the patients who you're treating locally are fluent in English, or the global population of patients having access to information in their own languages. And this is an interesting open research problem for people in natural language processing and artificial intelligence, where we have really amazing performing large language models for English and for many other languages that are well represented on the internet, but then there's a large set of languages that aren't as prolific in terms of the amount of documents available for doing this kind of self-supervised training. So those will be interesting challenges where if we care about equity across languages, that's going to be an important thing to address in the future as well.
But another question from the chat is also, how should we be evaluating the clinical utility of these tools? So this is like more of like a research question, and Kurt, you sort of addressed this a little bit when we talked about the regulatory topic, but should there be randomized controlled trials to assess impact on clinical outcomes? And this question has come up on just diagnostic AI and whether clinical trials, randomized controlled trials are the gold standard and how that should look based on the NIH principles of conducting trials. And actually, your colleague, Danton Char at Stanford, is working on this specifically with us. But what are your thoughts on, sort of the next step beyond diagnostic AI and generative AI and how that could be, studied and utility evaluated?
Yeah, very important question. I'll just say in radiology, we have, hundreds of applications that have been cleared. There's probably an opportunity for hundreds of thousands if you look at the number of conditions that we diagnose, the different imaging modalities that we have. So you have hundreds of thousands down to a few hundred. So the opportunity is massive. But even within that few hundred, I would say maybe only a dozen or so, maybe a few more have been evaluated in clinical trials. So there's a lot of work to do. We need more clinical trials to assess these important applications. But at the same time, we need to think about a spectrum of risk and what kind of assessment that each healthcare organization, customer, if you will make of these algorithms. So on the low risk side, we have some algorithms that measure things like the diameter of the aorta or the length of the femur. And I think in those cases, particularly when there's a human in the loop checking that measurement, that's a relatively there's relatively less need for a complicated clinical trial to assess whether that's an accurate algorithm or not. On the other hand, we have some algorithms now that propose, let's take some mammograms and have them never looked at by a human because they're so likely normal according to the AI. Now, that's something where I would want to see a clinical trial that shows that actually benefits patients. And there's some early evidence to show that it might, but again, I would want to see that because of the risks involved. From the other's perspective, so now, we're just faced with lots of algorithms. Some have clinical trials showing that they work well. Others don't yet and may never, I suppose. My colleague Nigam Shah here has a nice acronym called FIRM assessment that he's our chief data scientist at the hospital. And we use this rubric to decide on, to evaluate algorithms for their suitability. And FIRM stands for, is for fairness. So different patient groups. Do we get the right answer for each of the different patient groups? That's an important question. Usability, how does it fit into our work? Reliability, what's the actual accuracy, area under the ROC curve or sensitivity, specificity, those kinds of things. And is it, again, sustained over all groups? And then the M is more about monetary and sustainability. Is there a return on investment for implementing that? When we apply that, interestingly, one of the major issues that comes up over and over is just the capacity to act on the result. So just one example, we have an algorithm that looks at for peripheral artery disease, patients who have unknown peripheral artery disease based on their attributes in the medical record. Turns out the algorithm works very well, can identify those patients, but now, who is going to receive that information? Do we have the capacity in our vascular surgery clinic to handle all of those patients? Those are the kinds of questions. How does it fit in to the workflow? Another, coronary calcium. We notify patients who should be on statins. Do we talk to the primary care doctor, to the cardiologist, to the patient, to all three? How many alerts is a given physician going to receive in a week based on the patient population that we have? All of those questions are really important, practical questions that need to be addressed as well.
Thank you so much, Kurt and Chris. And it has been really insightful discussion. So it's 12:59 Eastern time. I cannot believe we are already wrapping up. I would like to invite all of you to our next webinar featuring Nicholson Prize of the University of Michigan. And also please consider joining our HBHR group on AI healthcare. And we'll be sending email to everyone with more details. And again, we thank you for your time. And especially we thank our two excellent panelists for sharing insights. Unfortunately, we cannot address all the questions, but we promise we will share all the questions with both panelists and invite you to continue this conversation. Thank you, everyone.
Thank you.
Thank you.